First of all, thanks for making it out despite the less than optimal weather. Welcome to Boston in December, or whatever time of year this actually is. For those who I have not had the pleasure of meeting prior to today, I'm Jonathan Marin. I'm the Director of Clinical Ethics here at the Center for Bioethics. And I'm truly thrilled to welcome everyone to our first session in our new Clinical Ethics Conversations series. Thanks again to everybody for joining, and we're really looking forward not only to this session, but to this series as a whole. And the fact that all of you have made it here speaks to the excitement around this topic and to the general community. We're joined today by two spectacular speakers who I'll introduce in just a couple of minutes. But before I do that, I'd like to take a moment to set the stage both for today's session and for the series in general. We've named this Clinical Ethics Conversations. We all get dozens of emails each day about lectures on one topic or another. Importantly, though, clinical ethics doesn't really happen in a lecture format. Clinical ethics and many other realms of bioethics involves and really requires thoughtful conversations, discussion, back and forth, and about all of these complex topics and issues that we encounter in the clinical ethics space. So that's really what we hope to provide with this series, a chance to learn about and to discuss some of the challenging topics that come up in clinical ethics, sort of the issues of the day that we're encountering in the world of clinical ethics. And that really is what brings us to today's clinical ethics conversation topic. Can artificial intelligence act as a clinical ethicist? Should it? While this topic is indeed intentionally a little bit provocative, it isn't a rhetorical one. It's not intended to be a rhetorical question. We've already seen just in the past couple of years that generative AI, or large language models, which is the type of AI probably that most of us encounter or deal with most frequently. Generative AI can pass medical licensing exams, and we've seen the same thing for specialty and subspecialty board exams throughout healthcare, and really not just for physicians, but for other exams across the healthcare landscape. Further, data that were just published in the past couple of weeks demonstrated that large language models actually can outperform physicians in one of the core features of medical practice, diagnostic reasoning, sort of developing a differential diagnosis. What are the list of different diagnoses that a patient might have? How do we distill that down to a single diagnosis? What do we do about that information once we have it? AI can do that better than we can as humans. And then finally, though often when people hear about work like this, their initial response is to say that, oh yeah, well, that's all well and good, but AI isn't human. AI can't do the human things. It can't listen empathetically. It can't do all these other things that we as humans can. For better or for worse, anyone who's gone to their own clinician anytime recently might argue that we as humans can't do all of those things quite so well either. But as it turns out, AI actually can do this. There have been studies that have demonstrated that large language models can effectively make people feel heard, providing some degree of empathy, and actually do so better than humans do. Interestingly, when speaking back and forth with an AI chatbot, if the individual on the receiving end, the patient or the person, knows that they're talking to an AI chatbot, is told ahead of time, then they perceive that as feeling heard less. But if they don't know, they perceive it as actually doing better than the human. So that's interesting. Some people call that worrisome, but this is all in the clinical space, in the clinical medical space, not so much in the ethics space. But it tells us that this provides some foundation, some context for the fact that this is where we are with AI in medicine and healthcare. It's not so inconceivable then, again, this question not being a rhetorical one, that will then be moving these same kind of concepts into the clinical ethics space, because certainly to be able to, the ability to perform reasoning, clinical reasoning, moving on to moral reasoning, empathy, moving on to other types of conversations and supportive procedures that we are so focused on in clinical ethics, perhaps it's not so unreasonable to think that AI might be playing a role, if not a central role, in clinical ethics practice. And so that leads to some of the questions that we'll be exploring a bit today. So one, can AI perform moral reasoning? Would this be acceptable? Would this be consistent? Would it be reproducible if we asked the same large language model to approach the same kind of things multiple times? And how would this impact current practicing clinical ethicists? I think that some of this comes off as a little bit far afield, but an important test case. Just this past week with the Masters of Bioethics students, we presented a case of resource scarcity, of rationing. This is a case that we've presented many times over for a number of years in various different settings with different groups of learners, anywhere from our bioethics graduate students to medical students to students in other graduate schools, practicing clinicians, everywhere in between. It's a case that at least a handful of folks in this room are aware of. Some folks in this room were involved in the initial case that was the impetus for this teaching case. It involves 4 eligible patients for a resource in scarcity, which were 3 ECMO circuits. So 3 circuits, 4 patients who need that resource. We present this and talk this through with our students to try to figure out how we would make these decisions in an ethically supportable fashion. And out of curiosity, we fed the information in the case to ChatGPT. Interestingly, the large language model actually provided responses that were very similar to those that we consistently hear from our students when we're talking about this case. And interestingly, when we then pushed the AI a little bit further and said, okay, how would you handle this differently if this were, for instance, in a crisis standard of care? How would that change things? And they made the same adjustments that we would quite often as practicing clinicians and ethicists. And not for nothing, the AI was even able to accurately reference various relevant ethical frameworks, allocation principles, competing considerations, all of the things that we would hope that a burgeoning clinical ethicist would do themselves. And so I feel that in some ways this comes across a little bit as the introduction to some post-apocalyptic movie. I'm going to change the slide and then you're going to see the robot foot crushing the skull or something like that. That's a very dated reference. But I don't mean it to be like that, but rather just the fact that these are the conversations I think that are important for us to have. AI is here. Its impact is already being felt across the span of healthcare. And it's likely that not only here at Harvard Medical School, but really everywhere across the globe, this is something that is going to be a part of our everyday lives. And it's sooner rather than later going to be coming into clinical ethics practice as well. So what are our plans for today? So for today, we're going to explore this very concept just a little bit. We'll be focusing largely on large language models, since that's the type of AI that's likely most relevant to us for right now. We'll start by hearing from a couple of leading experts about their distinct perspectives on this issue, and then we'll open things up. I'll sit down with our 2 speakers for an open conversation, including we'll take some questions from you in the audience, time permitting. And so that all being said, without further ado, I am absolutely thrilled to introduce our 2 speakers for today's session. First up, we're joined by Professor Spencer Hay. Spencer is a philosopher and researcher who provides a really unique perspective on this topic. Spencer trained at the University of Western Ontario, where he received his doctorate in philosophy. He then had additional training at McGill and Oxford, and for many years he was here faculty at the Harvard Center for Bioethics as our Director of Research Ethics. And he's done a great deal of work around the intersection of bioethics and the philosophy of science, particularly around developing new drugs and new knowledge and how we can do so more effectively and efficiently. Currently, Professor Hay is the Chief Scientific Officer and co-founder of Prism Analytic Technologies, which aims to speed and improve analysis of clinical trial data using AI and other technologies in order to improve the speed and value of knowledge acquisition. And after Professor Hay, we'll then get to hear from Dr. Andrew Hantel. Dr. Hantel is a medical oncologist researcher and clinical ethicist at the Dana-Farber Cancer Institute, an assistant professor of medicine here at Harvard Medical School, and a member of the Center for Bioethics. Prior to coming to Boston, Andrew completed his medical training at Loyola and then his residency, hematology oncology training, and clinical ethics fellowship at the University of Chicago, after which he came to Dana-Farber for his cancer population sciences postdoc fellowship. Dr. Hantel's work utilizes health services research to explore ethical dilemmas in cancer care, including, but not limited to, some of these issues related to AI. So again, a huge thank you to all of you for joining us. And with that, I am absolutely thrilled to introduce Professor Hay to start us off in our clinical ethics conversation.
Thanks everybody for being here today. Thanks so much, John, for the opportunity to come and speak. And it's been really great, even just thus far in planning this event, to engage with you and Andrew on a number of occasions, just sort of talking about what we want to do, tracking these ideas. I mean, we've been talking about this for several months, and it's just, as I'm sure we're probably all aware, this is a field that moves so quickly that I even think, like, since we started talking about this, whatever that was, 6 months ago, things have changed, right? So what we're sort of going to get, I guess, reflections on, at least what you're going to get from me is reflections on kind of a snapshot of where we are today. I'm going to talk a little bit about some of the, I hesitate to even call it technical aspects of how large language models work, because you can get very technical with that, and that's definitely over my head, but I'll sort of talk a little bit about how they work. I come at this as more of a sort of product developer, a researcher, a user of the tool. And so I'll start with kind of giving a sort of high-level understanding about how these large language models work, and then I want to sort of transition to talking a little bit about how I've used them, look at some experiments that I've done, trying to understand, in some sense, if you can teach a large language model about ethics and sort of get it to go beyond just kind of the baseline of what you would get just going and sort of asking a question into ChatGPT or something like that. So that's sort of the structure of what I'm going to say. Okay, so beginning with large language models. So, and I apologize, this may be sort of, old news to everybody, but it's worth for any who may not be familiar with this, just sort of this level of it, getting it all on the same page. So large language models are tools that are trained on vast amounts of text data. So basically, it's almost like everything on the internet has been sort of fed into these neural networks. It's a deep learning process where they're sort of given this task of basically, here's this body of text, now predict what the next token is, right? The next word or the subword, right? Now, this is really sort of simplistic example, but just to sort of fix ideas, right? The way it works is you sort of give the, large language model a sentence like the cat sat on the, and then ask it, well, what comes next, right? And it's supposed to make a prediction. And the likely predictions are things like mat, sofa, floor, right? And it's just sort of interesting, I think, when we, because we'll look at some examples of the things that large language models do, and if you've used them, you've seen them do, I suspect, probably pretty amazing things, like John even alluded to these already, right? And it all sort of comes from this root of just, here's some text, well, what comes next, right? What comes next? And it's sort of interesting, I think, to think about the technology in that way. But that's sort of the core of one of the cores of how they work. Another core piece of a large language model that makes it really powerful is this thing called the attention mechanism. So this is a method that allows the model to focus on different parts of the input sequence when processing or generating text. And so, why does that matter? Well, what it does is it helps the model determine sort of which words or which tokens, which are like subwords, are relevant to each other in a sentence, right? So, and sort of have the example again at the bottom, right? And so the way that it works is like each word in the sequence or each word in the sentence is sort of given a weight relative to every other word that shows up. And it's sort of trying to capture kind of, in some sense, the meaning of the different words and how they relate to each other, right? So in the sentence, the cat sat on the mat, the word cat has a strong relationship with sat and mat, right? There's a visual here that I think makes this a little bit easier to understand if you're a visual thinker like me, right? So if we sort of look at this sequence of words on the left, so the doctor asks the nurse the question, period, she said, what this sort of, what do we call this, like a sort of a Sankey diagram or something like this? But anyways, what these sort of lines are meant to represent is sort of the weights that the attention mechanism is placing on this word she, right? And sort of showing that she has this relationship, it thinks, to every other word in the sentence, right? And the stronger the coloring, right? The stronger the blue, it's the suggestion that like that is the word that is most, more associated, right? The weight is stronger between she. And what's interesting to note here is that, it associates she very strongly with the word nurse, right? Whereas in the other, sort of on the right side here, the doctor asked the nurse the question, period, he asked, you see that sort of there isn't that association with the pronoun, with nurse, right? that gets at a couple of different things. So one is, this is just an illustration to give you a sense of like how the attention mechanism works in a large language model. This is the kind of thing that it's doing when it's making sense of the input text, right, and generating its output text, is sort of trying to get this right, in a sense, predict what makes sense for, you know, what next word or next token should come. It also is illuminating a bias, right? And this is something that we'll be able to talk about that comes from its training data. And the idea is that, you know, the pronoun she, right, is much more strongly associated with nurse, right, than the pronoun he. And, you know, there's another token there. You could sort of say like ask seems to be referencing the doctor and so forth, whereas said maybe it's sort of more naturally is talking about how the nurse responded to the question. But it's just important to think about that as well, that like there's this body of text that, you know, these language models are trained on, right? If there are biases, you know, in this case, sort of gender biases or sexist biases that may exist in that text, right? That will be reflected in the output of the language model as well. And it's worth thinking about that. We're thinking about how to use these things, right? How to use these things well. Okay, so a little bit of technical background. Hopefully that makes sense. I don't know that I can explain it much better than that, but we can sort of pick that stuff up in the question period. So I want to sort of turn now thinking about, okay, this is how large language models work. Turning now to sort of think about, okay, what if we wanted to use these large language models? And I'm particularly sort of thinking about the chat like interface, right? Where you can ask a prompt or you provide a prompt to the sort of the language model and it comes back with a response. So, you know, I know this is a little bit cheesy, but I decided, you know, in preparing for this talk, you know, we'll just sort of as an opening, like, well, let's just sort of put the question to ChatGPT, right? And say, like, I'm interested in using a large language model to help me think about clinical ethics. Is this a good idea? So I think this is interesting to look at for a couple of different reasons. One, I mean, we'll look at it in a second. I actually think what it says is like pretty reasonable, but also it's like providing a baseline that I think is really important. At least this is something that I worry about as a sort of researcher and a producer of knowledge products, right? Sort of thinking about like, you know, what can just sort of a language model like ChatGPT just sort of like do straight out of the box, right? And what value then am I going to be adding to this, right? If I, you know, want to sort of be contributing to the discussion here. So, okay, so put this question to ChatGPT. It says, you know, using a large language model to assist in thinking about clinical ethics can be a good idea if approached with clear goals and proper precautions. Here's a breakdown of the potential benefits and considerations. So what does it say the benefits are? So, you know, broad knowledge base. So LLMs are trained on vast amounts of text, which can include bioethics, literature, case studies, theoretical frameworks. This can provide diverse perspectives or highlight relevant resources. Can facilitate discussions. They can act as sounding boards to generate ideas, frame ethical dilemmas, simulate conversations between stakeholders, helping you explore various angles of an issue. Scenario exploration. You can use the LLM to create hypothetical case studies, analyze ethical considerations across multiple viewpoints, aiding in education and decision-making. Right, it can help ethics education and awareness, help students or professionals better understand the principles, such as autonomy, beneficence, non-maleficence, and justice, providing examples, definitions, and explanations. So, you know, a little bit, maybe sort of adding to the example, John, that you alluded to, right? You know, it's sort of, it's unfolding things that hopefully, if, you know, those of us who have some familiarity with bioethics, right, this should look familiar. Like, in my view, this isn't a million miles off of what, you know, a good starting point would look like for this sort of what we're considering today. So considerations, also want to flag, I think it's interesting, it doesn't call this risks. It sort of says, here's some things to be wary of. But again, you know, I think reasonable. So accuracy and bias, I already alluded to this, right? And it does actually hit on something that I think is really important. So I'm going to emphasize this later on as well, that LLMs do not understand ethics, but they rely on patterns from training data. And so they are likely to reproduce biases, or, you know, they may provide incomplete or outdated views. It recognizes context sensitivity, right? That there may be sort of nuances, case-specific judgments, things that like the LLM might struggle to pick up on, right? So if you think about, you know, the attention mechanism, right? Like, you know, that's just assigning weights to the words. That's going to capture some of the meaning, that might not capture all of the meaning, it might not capture it accurately enough, right? In a way that a human might be able to do, right? And that can have real consequences. Of course, there's issues about confidentiality, right? You know, you want to be sort of sensitive to putting patient confidential data in there. Human judgment, right? LLMs should not supplant, or should supplement, excuse me, not replace the expertise of ethicists, clinicians, and institutional ethics committees, right? Always validate insights with human experts. And then accountability, right? So, you know, we shouldn't just be offloading these decisions to the LLM. So the LLM says, the accountability rests with us. Okay, best practices. So it says, you know, clear prompts. So you should frame precise ethical questions or scenarios for the LLM to analyze. Use it as a supplement, right? So just as an aid for brainstorming or research, not a definitive source. Cross-check, verify the information, reputable sources, consult with clinical experts, and guardrails, right? Think about it as a sandbox environment, set clear boundaries, right? Particularly for sensitive or high stakes applications. So I don't want to sort of linger here too long, but again, I mean, I feel like not bad, actually. Like, not great. Like there's, certainly more that would have to be, spelled out here, but just sort of providing like a baseline for thinking about this issue. I just think it's interesting to see that the LLM, has surfaced a number of things that, if we wanted to, as we're contemplating this question, right? It's like, okay, like you could sort of, imagine teaching a class and maybe you just sort of go through each of these bullet points one by one and say, look, let's talk more about it, right? What do we think about these things, right? What does this mean? So, we can take those up potentially in the question period. What I sort of want to pivot to now, though, is actually sort of going a layer deeper. So one thing that you'll notice here, right, and you can get ChatGPT and other LLMs to do this, is that sort of these recommendations aren't tied to anything sort of like deeper, right? That is to say, in this particular output, you don't get a source for like, well, why are these the right principles, right? It's just sort of, it's giving you a bulleted list. That's what the internet is great for, right? Just give me a list of these things. That's what it was trained on. But I think if you really kind of want to understand, how or why, right? Like if you wanted to kind of push this conversation further, I think in my experience, at least, ChatGPT and other LLMs, there's still kind of a gap there, right? Like it's really great for just this kind of first pass at stuff. But when you want to go further, there can be challenges, particularly as you want to engage in things that are sensitive, like ethics. So what I'm going to now pivot to is talking about some of the work that I've done with LLMs, and particularly the chat interface, and some of the insights, and then I'll offer some reflections, and then I will sit down. So one thing that I think is really important in working with LLMs is actually to sort of always bear in mind that it's just a tool that takes in text and gives back text. And now I've added an asterisk here, which I'll just sort of explain really quickly. So, again, the technology is moving really quickly now, right? So like now it's actually, you can give it more than text. You can give it pictures, you can give it sound. There's sort of multimodal models that you can put in other things besides text. You can get back other things besides text as well. You can get back pictures, you can get back voice. I'm going to sort of be sticking with the sort of text in, text out. It's a little bit easier to illustrate on slides. I think most of what I have to say applies broadly to those other modalities, but just sort of sticking with that example, I do think that it's really just important to sort of always bear that in mind, that even though this sort of chat bot or whatever that we're working with, it seems intelligent, it seems smart, right? Like it's, I mean, and I think John alluded to this, right? It can sort of seem like there's empathy there. It's really just a tool. It takes in text and gives you back text. And where you have a lot of control is that text that you put in. And so I think, you can ask ChatGPT a silly question and you're usually going to get a silly answer. There's definitely sort of a garbage in, garbage out. Definitely applies to using this tool. However, by sort of carefully curating or crafting the input, sort of thinking, I think you hear this less now, but I know when these things first launched, there was all this talk about like prompt engineering, right? Or prompt architects and things like that, which is maybe a little bit silly, but there's a truth there, which is that sort of being kind of rigorous and thoughtful and systematic about, well, what do I need to put in order to get out a particular output that is of a quality, or reliability or value, right? That's really where I spent a lot of my time. I think it's really interesting, and there's sort of ways that you can do this that I think are powerful and that bear on this question of thinking about how could we use sort of an LLM or generative AI in the context of clinical ethics. And that's what I'll talk about now, sort of picking up this question, well, what does this careful curation or crafting of input mean? And I'll just go through one example, really. It's an experiment that I ran that sort of, I framed it to myself initially as this sort of idea of, well, can an LLM be taught ethics? Taught is in scare quotes. I don't think it's really right to think of it that I sort of taught it this, but what I wanted to do was sort of see if I could get out of an LLM, in this case, it was ChatGPT or GPT-4, if I could get out of it sort of something that went beyond this sort of bulleted list. It looked much more like kind of a real, what I would call kind of a real sort of ethical analysis. And here's the strategy that I took. So I uploaded basically dense articles that were relevant to the principles of bioethics to the LLM. So just PDFs in this case. And for each of them, I had a sequence of prompts that I ran. And so my background is in philosophy, I think, as John mentioned. And sort of I did kind of what would, in analytic philosophy, is kind of a standard sort of analysis where it's like, cool, I have this article, great, I'm going to outline it. I need to break the argument down, just kind of like flesh out, like, what is in each section, what's the sub-argument. Then I would ask always like because I knew these articles well, I would ask for a deep dive in a particular question that I thought was going to be relevant, and then get a summary out. And so, upload this document, and then in a way kind of created what I called like a distillation. It's kind of just getting that outline out, right? So that, if I'm going to, eventually use this sort of a refinement of this paper, With the LLM, I'm not giving it, whatever it is, like 30 pages, and it has to kind of figure out what's relevant. I've sort of distilled it into this is kind of the core of this argument that I'm interested in. And then I combine those distillations into a new document. And then I would upload a case scenario and then upload my distillation and sort of offer that as my ethical theory. And then I would ask the language model to kind of put these things in conversation with each other, right? So the idea was, in a way, the kind of like teaching it ethics, right, is sort of creating this theory and then trying to see, can I get the LM to deploy it, right, where I understand where the information has come from, right? It's not just going into what it learned from the internet. It's kind of, I've given it the resources and I'm like, great, I think these resources are important. I've captured what I think is the, kind of the key ethical argument, and I want to see, can it use it? Does that make sense? Okay, cool. Okay, so get into the details a little bit here. I'll just show kind of one piece of this, which was focused on autonomy. And so the 3 articles that I gave it were Freedom of the Will and the Concept of a Person by Harry Frankfurt, Autonomy and Personal History by John Christman, and Personal Autonomy, What's Content Got to Do with It by John Santiago. I sampled these articles from a grad seminar that I ran when I was a faculty member here. This was so much fun to teach this unit and see all the students engage with these in the course. And so I thought, like, this is great. I know these articles really well. I even had that baseline of like, what did the students kind of do with these articles, right? How did we understand it in class? To kind of see, like, could I get the language model to do something almost student-like, right? Kind of learn these articles and do something reasonable with it, right? These are dense pieces. I don't know, has anyone read any of these articles? Yeah, okay, just one. That's okay. Anyways, highly recommend them, super interesting, but these are like philosophical articles, right? Like they're challenging, but they're all pretty different. The first 2 are maybe sort of closer in conversation, but there's a nice constellation because I know the articles well. I sort of knew, like, okay, we can kind of connect the dots between these 3. We'll have an interesting theory of autonomy. Okay, and then the case I gave it was this article, Eyes Wide Open, Surgery to Westernize the Eyes of an Asian Child by Alicia Ouellette from the Hastings Center report in 2009. And then basically I said, like, okay, here's this case. Now, give me an ethical analysis. Use these resources in this sort of theory of autonomy and break this argument down, or break this case down. Help me understand it. And so I'll just show you what it did. This is a little bit excerpted. But I asked it to provide an introduction to the case. And so I'll go through this quickly. And so the case in question, it wrote, involves a father who decides for his adopted Asian daughter to undergo cosmetic surgery to add a crease to her eyelids, a procedure known as Asian blepharoplasty. He believes the surgery will improve her appearance and her prospects for assimilation and success in a Western context. And this decision raises profound ethical questions about autonomy, parental rights, and the impact of societal beauty standards on an individual identity and self-perception. Relevant ethical theories and concepts. So central to our analysis are the concepts of autonomy and reflective self-evaluation derived from the works of philosophers like Harry Frankfurt, Christman, Santiago. So nice, citing the resources. I like that. Autonomy in this context is understood not merely as the freedom from external constraints, but as the capacity for an individual to reflect upon and endorse their desires and actions in a coherent manner. Reflexive self-evaluation is crucial for developing autonomy, enabling individuals to form desires about their desires, what Frankfurt terms second-order volitions. Illustration of the theories and concepts applied to the case. Applying these concepts to the case, several ethical concerns emerge. First, the child's autonomy and capacity for reflective self-evaluation are at risk of being compromised. The decision for surgery made by the father without the child's input overlooks the child's potential to form her own judgments and preferences regarding her cultural identity and appearance. This act can be seen as prioritizing external societal norms, specifically Western beauty standards, over the child's internal process of self-development and identity formation. It goes on, I'll just jump to the conclusion. The decision to subject a child to cosmetic surgery aimed at altering her ethnic or racial appearance without her ability to participate meaningfully in that decision raises significant ethical concerns when examined through the lens of autonomy and reflective self-evaluation. Such actions not only risk undermining the child's future autonomy, but also fail to respect her current and developing capacity for self-determination. Therefore, the ethical stance posited here is that elective cosmetic surgeries on minors, especially those that alter racial or ethnic characteristics for the sake of assimilation or aesthetic preference, are ethically problematic. It goes on a little bit. We can talk more. I'm pretty impressed, actually, by like that. Like, again, there's much more subtlety that it could go into, but that is far beyond just kind of like surface level bulleted list. It's citing the references that I gave it, and it is deploying those resources in a way that struck me as sort of prima facie reasonable, if not, pretty good. Like if I sort of think about, this was like a term paper that was like presented to me, pretty good term paper, right? Like, they've done a good job. Again, it's short, but I thought that was powerful. Sort of stepping back, just to reflect on the experiment, what this sort of helped me see in similar types of experiments that I've run is that really getting higher quality output from LLMs, what I would say kind of getting them to be ready to kind of like take on some of the responsibility of clinical ethics, perhaps, it requires some work, right? So I think at the minimum sort of requires curating this set of resources that the LLM can deploy. And thinking about, well, how do we sort of prompt this system in the right way, or put up, kind of like system prompts, for example, to support users, right, to kind of guide them, or guide the LLM rather to be giving them the answers that we want it to be giving. But I think that work is worth it, because it improves, I think, both our understanding of like how these things work, and also trust, right? Because I sort of had curated those papers, I was sort of confident in the output. I could sort of see, yeah, okay, it's not just making this stuff up. I understand where it's getting these ideas, and I can see that it's using them in a reasonable way. And that work actually, I think, is additionally valuable because you can translate that to other projects and applications. Other reflections, and this is sort of stuff that, we hit on in the beginning, right? I mean, I would sort of, agree with ChatGPT's own assessment, right? I think the way to think about this, though, is still, it's an accelerant and not a replacement for critical thinking, right? Like I'm able to, I think, appreciate the value in that, what I would consider to be a higher quality output, because I know those papers well, right? But if somebody doesn't know those papers, then you can't tell the difference, right? And so the way that I would sort of think about it is like, use this as a tool, right? Like furnish it with the resources that we know should be there, to aid our critical thinking, right? Not to replace it. But certainly I sort of see this as an opportunity to really sort of be able to kind of level up that first pass analysis. If we think of like what an analysis needs to be, text of some sort, right? Being able to kind of like bring my case, right? And say, okay, I know we have this nice set of resources. Let's deploy it. Help me think about this in a sort of rich way and tie it back to the stuff that I trust. Okay, I won't go through all of this stuff because I think I'm at time, right? Okay. So I will wrap up quickly. Sort of, there's a whole bunch of like broader reflections here. Yeah, I'll just like hit on a few of these. I mean, I think the value is definitely in LLMs, is potentially kind of eliminating some like tedium, freeing up mind share. LLMs don't get tired, right? So you can kind of like, you could imagine having a sort of ethics support or something like that if it was good, like, 24/7, right? And there could be sort of value there, right? Particularly if, it's relaying then kind of insights to, humans, right? Who can act. To talk a little bit quickly on some of the cons that I think are actually interesting though. So one is like the indeterminate output, like, and I think, John, you talked a little bit about this already, is like you could ask the same prompt, or you could put in the same prompt and get back something like slightly different. And there is a sort of interesting thing when you ask a question like about ethics and you get an answer like, okay, that makes sense, cool, I'm good to go. But if you said like, no, I'm gonna ask you again and again and again and again, and you walk away with like 6 answers to your question, right? It's a little bit kind of different to think, I don't even yet know kind of how we should think about that. So I think there's sort of, definitely more work to be done kind of like parsing like, okay, what does that mean, right? Does it need to be totally deterministic, right? Or is it okay that sometimes you kind of get back a little bit of variation? And then I also want to think a little bit about like, if these tools become more embedded, like what is lost if we're, for example, like not discussing these things with colleagues, right? It's like I think of the AI as my assistant and I go to that, right? Rather than talking with my colleagues about those things. And there may be sort of, a loss in that sort of engagement, as well as then potentially kind of like offloading the ethical understanding, right? Like if I'm sort of not taking this all in and kind of making myself the, sole source of ethical truth or something like this, but I sort of, no, I, just like I rely on my AI to like help me think through these things, if there may be something lost there as well. And those are things, I don't know the answers to those, but I sort of recognize those as costs that I think are interesting and worth bearing in mind. So with that, I will stop and hand things over.
So thanks for having me, Jonathan, and for Spencer and your wonderful talk to proceed this. So I'll be working off these kind of prior two talks to think more about the clinical aspects of if artificial intelligence can act as a clinical ethicist, and also a little bit about kind of what the constitutive elements of clinical ethicists are and kind of how those factor into AI entering this space. I'm also going to get into, not necessarily my disclosures, but more about the future thinking, more than Jonathan wanted me to, I think, about, the question of that was asked at the top of this topic, which is if AI can actually act as a clinical ethicist, not necessarily just as like the co-pilot or assistant that Spencer just talked us through. So a little bit future thinking, but I won't dwell on that too much, just a little bit at the end. I think, as I said, wanted to start off with a little bit about, well, what is a human clinical ethicist, and then how AI could enter that space. I have a couple pictures throughout this, one of which is here created by Dolly, and you can see what it thinks a clinical medical ethicist is, albeit with some misspellings that you can see at the top and the bottom. So this from the ASBH, which set up a kind of guidance documents about clinical ethics consultation, has a nice certification process and everything. And so rather than me just coming up with my own opinion about what a clinical ethicist is, I wanted to derive, or excuse me, kind of use their explanation of it that you can see on the bottom. Talks a little bit about what they call a clinical ethicist. And I'll just kind of use this definition to go into it a little bit in saying that the ASBH is saying they, meaning the clinical ethicist, a person, has been assigned by their institution, kind of delegating authority to a distinctive role of responding to specific ethical concerns and questions that arise in the delivery of healthcare. So they're kind of saying that there's a specific role there, and there's a specific differentiation of that role, a scope of practice. With the delegation of authority, there's also kind of a delegation of power, an assignment of power to this person, and therefore they're different and have power relative to things like ombudsman, to HR, to a general counsel, to chaplaincy, patients and family relations, and to the police, which oftentimes when people calling ethics consults, they say they're concerned because we're calling and they're kind of knocking down their door like we're trying to blame them for something. But I think with some of these things, you also have on the bottom there this distinctive sets of competencies, which are the requirements of the roles and kind of what an ethicist might need to do to kind of fulfill them and be an actual clinical ethicist. And so with that last point, I wanted to break out what the ASBH said are necessary competencies for clinical ethicists. These have kind of been structured into what the ASBH is calling knowledge, skills, and professional attributes. And really, the first one kind of demonstrating and understanding theory, practice, and culture, and being able to apply this understanding through cases and reasoning and analysis, and going through really this process of consultation, and doing so in a way that facilitates and really makes the overall objective of helping stakeholders navigate clinical ethics issues and concerns appropriately. And then we both have the kind of essential and albeit more vague issues at the bottom of professional attributes, which include integrity, humility, self-awareness, as it talks about here, as well as maintaining objectivity and avoiding personal biases. And as I mentioned before, this is not a presentation on the definition really of an ethics consult, so I don't want to debate whether or not all these components are sufficient, essential, or the like, but really to have us think if AI is being integrated into all of this, what are we debating that it might need to enhance, to support, potentially even do by itself, and really what are the opportunities and concerns that come with that. And so broadly, I think there are two ways in which AI might interact with clinical ethics. The first is a lot of what Spencer went through, which is how can AI really be a co-pilot, a partnership, if you will, of a human ethicist that uses interactions with AI as an assistant. And it can be checking work, answering simple questions, but really the ethicist is still the ethicist. They're kind of performing all the essential functions. And then there's the AI ethicist model, which I said I'll kind of get to a little bit at the end, which is this more autonomous model where the AI would actually be the ethicist, potentially somehow meeting with patients and families a little bit more far-fetched at this point. And I've dichotomized it here for simplicity, but I think there is a continuation between the, a continuum between the two, really kind of talking about delegation of tasks from the ethicist to the AI in terms of information gathering, in terms of potentially reasoning, or at least some form of it, as Spencer showed us, as well as other aspects of clinical ethics consultations, like maintaining a database of ethics consults, writing the ethics consult note, those kind of things. So the way I kind of introduced that was a little bit more narrow than the ways in which AI might actually be integrated into ethics consultations. The first is that we as clinical ethics consultants might actually use an AI co-pilot during different aspects of consultation. We might have it do information gathering for us from the medical record, since they are ever more voluminous and may become even more so with the use of AI. And so rather than spending hours wading through that or getting incomplete information from people who we talk to on the phone who are calling the consults, we might use the AI to do a portion of that. We might actually have it kind of record our conversations during the process of the consult. We know that we can only take notes so quickly. We remember things fallibly, and it might it might kind of prompt us with things that we're writing down incorrectly. It might prompt us to say, hey, you forgot about that part of the conversation, or you forgot that person's name that they said you might need to talk to. So it could be even as simple as kind of helping us out with those different things that we realize our memories are not perfect at. It can also have us, prompt us to ask, let's say, more relevant ethical questions based on past consultations, maybe to make us, if it's curating a database of our prior ethics consults, make us be able to reference those consults in the past, bring up similar ones. We know that in larger institutions, there are multiple ethics consultants. And so I think we should be concerned that having a different consultant on a different day of the week is going to give the patient family a totally different answer. And if we're able to go back, not only for the current consultants, but for the past 10 or 15 years of consultants and say, are we being consistent with what we've told patients and families and clinicians previously? Are we making different decisions over time? If so, that might be okay, but at least we can know what we're doing, know how things are changing. We can have it then scrape the medical literature, feed it different ethical systems to say, have we, thought about this aspect or this aspect? You can even do, more simple things like helping us schedule the family meetings, help us, correct our language when we're talking to patients and families and say, am I using medical jargon that is completely incomprehensible? Because I know as a clinician, I do that more frequently than I would like to admit. And then, we can talk about that more and more. But I think those are kind of some of the ways, at least from the ethicist standpoint, it can be really involved in AI consultations. But that's really only the first of these 4 ways. The second is that, when we're having consultations or when there's ethics questions in general, there's a whole bunch of people in the hospital that are not ethicists, but they also have access to AI and all of the, at least for the generative AI like ChatGPT, they can ask it questions about their medical care, often which are, if not directly involved with ethics, at least indirectly have those cues in there. And so we really have to think about how they might be bringing that into the consult directly, indirectly. Their opinions might be informed by those things, and their ability to actually use them in ways that aren't just superficial, like Spencer mentioned, but kind of using them in a way that might be informative and maybe not leading to more kind of misinformation entering the room. Beyond that, I think we also have the idea of us as individuals bringing these tools into clinical ethics, but also the fact that we have institutions, organizations, Epic, all these other systems that are being putting AI into the clinic room and into clinical ethics, maybe without really our asking them to. There may be situations, and there are already a lot of pilots at Dana-Farber where we're being asked to use different recording things to help us out, with our notes, and there's a variety of hospitals that are using them as scribes and other things. And is that going to become a standard that your hospital recommends you do this because it's going to improve your efficiency? And then you have kind of the concerns, the ethical concerns with that if you're asked to use it in your consultations, because there's also recent data saying that a lot of those conversations, there are hallucinations in there when the doctor ends up looking at it afterwards. So are you actually having these recordings bringing you something as an ethicist that is the truth, at least as it was just spoken out loud? And then we have all of these kind of penumbral areas of the AI really helping us identify consults. I think one of the biggest issues and bias in clinical ethics is who's actually bringing us consults, because we have a number of things that we would probably, if we're walking on the wards, we would probably consider this as maybe an ethical or a situation that has maybe need for our input. I know that there's been a variety of studies more in the ICU with kind of having proactive ethicist rounding. Those have obviously shown profound differences in the types of consults that are produced, the types of patients for which they are produced, and all of those kind of things. And then there's also the more I would say perfunctory things like documenting consults, to some extent perfunctory, and then database curation. This can be an entire hour talk, just the slide. This is just kind of the large number of, I would say, domains of opportunities and hazards that AI has for clinical ethics. A lot of these overlap with clinical medicine. And they include kind of very long-standing issues and concerns for medical ethics on the left, things for which there are kind of new ways that these issues and concerns are being thought about because of AI in the middle, and then somewhat kind of new in kind things on the right. Really, things that aren't new are things like data ownership, which we know have issues when you're needing to kind of upload these patient data to a cloud to be able to process them alongside the other billions of internet web pages that these things have scraped. Issues with privacy and security that also come with that. And then also actually issues of patient safety as much with these AI tools, not necessarily just with LLMs, but the idea of having AI-powered devices in medicine. There's been a couple of different studies from the Journal of Medical Informatics where they've shown that a lot of the issues in patient safety having to do with AIs are more like errors in how the data is going into the AI. There's some amount of actually errors happening within the AI process itself, but mostly on kind of the inputs and outputs and on how we're connecting with the device. With the things in the middle, we obviously have these issues of responsibility and accountability. If we're talking about a human ethicist with AI, we are presumptively saying that the human ethicist still takes responsibility and accountability. But even if that's the case, if we are kind of offloading some things onto the AI, especially if we're offloading things onto the AI as prompted by our institution or somebody else to use the AI in the first place, it just feels like we have less responsibility and accountability. And there's definitely something to be said about a diffusion of that. We have discussed a little bit, and we don't have to dwell too much about the representativeness and the bias of the samples that the AI is using and how really feeding it different information from different ethical systems to the he and she in that sentence can lead to the AI just really being a mirror of our biases and accelerating them. And then these issues of professionalism, if we think or we are talking to an AI where it seems to have as much or more knowledge because it's able to kind of instantly and in perpetuity kind of scrape everything that John Locke and everybody else has said and again kind of presented to you. We feel, at least qualitatively, I've felt that when I'm asking it questions, it has so much more knowledge about every particular area of ethics, maybe not in a very deep way, but at least it's able to kind of reproduce these things enough that I feel like I used to be here and I have more knowledge than, let's say, the clinician about ethics, about the patient about ethics, but now the machine is over here and I'm kind of being pushed a little bit this way towards everybody else where I'm not really the expert anymore. I'm more relying on something else to really provide us with some of this knowledge. And I can still maybe be that gatekeeper, for better or for worse, to be able to kind of bridge that. But there is something to be said about our idea of professionalism. And it might be more about people who are entering the field more than people who are practicing ethicists for years and years that may feel that. But right now, this is where we're kind of entering this space where people who are entering the profession are going to be using these things potentially more than we have in the past, and that's going to be coloring kind of what they feel about their professionalism. And then we have the issue of oligopoly with the fact that a lot of these larger, more general LLMs are owned by very large companies that have goals very different than medicine. And just thinking about that, but I won't go into that too much more. The idea of artificial empathy, I think, is also one that has been touched on already. More the idea that if we express empathy kind of the same way each time in perpetuity, is it actually going to be felt the same? The example would be thoughts and prayers after school gun violence feels much less relevant the 50th, 100th, 200th time you've heard it. And if it's just the machine kind of prompting some kind of expression of empathy each time to a patient or to a clinician or something else about moral distress, it's probably not going to feel the same. And it also brings up the issue of if empathy is only really about the person receiving it or also the person generating it and kind of the effort it takes to do that. There's also those issues of hallucinations that we've spoken about already, but I think the other couple of things are really if we have a higher bar of inexplicability, because I can't really reach into Jonathan's head and kind of pull out his reasoning for why he's saying something about an ethics consult that we talked about last week, the same way that I can't go into the innards of the silicon and ChatGPT and pull those out and understand them. And yet at the same time, I feel like I have inherently more trust in Jonathan than I do in the machine's reasoning. And beyond that, we also have some unintended consequences in terms of environmental impact from these machines, as well as the concept of digital twins, which is kind of a fun one where people have been essentially trying to create twins of patients to simulate, in some cases, clinical things on them to understand how they might react without actually putting the patients at risk. But there's also an ethics version of this, which is slightly different, which is more about kind of scraping the internet and everything that has ever been written about this person to be able to understand what they might think in a situation where they don't have capacity. And it's kind of almost more of like a Greek chorus, where you think about, if we can't find a person for you when you're on a ventilator to be able to help make decisions, we can't find your friends. We don't know too many people that know you. We as clinicians have only seen you in this position. There's often kind of the idea of the Greek chorus of clinicians trying to do the best they can to figure out what this person would have wanted, going to contacts and everything else. And would it be better for the AI to kind of look through all that person's past history and come up with a reasoning about what they might want to do in this particular situation? So I think I got through most of that. The other thing I wanted to think about was, if we think these ethics, AI-enhanced ethics consultations should really be recommended and obligatory, and really if we do, in which settings. I think we need to acknowledge that we sit in a pretty privileged place in the fact that many hospitals, nationally, internationally, don't have a bevy of trained clinical ethicists. And so we really have, kind of a surfeit of resources to go to a number of different people and kind of get expert opinions. But in the case where you have either, nobody there on the weekends, let's say, for ethics, or if you have a hospital that just doesn't have any highly skilled clinical ethicists, is an AI ethicist or an AI assistant for somebody who has nominal ethics training better than that same person without it? I think it gets a little bit to Jonathan's question about, or Jonathan's point that he made at the beginning about having an LLM versus a clinician on a diagnostic reasoning test, and the LLM did better than both the clinician by themselves and the clinician with the LLM. And that was actually because the clinician with the LLM still had a lot of anchoring bias about their diagnosis. And so you end up having the issue that we as people are going to have our biases get in there. And this gets to the second point, that we have, burnout, we forget our information, as I've mentioned, we have our own biases and personality quirks about clinical ethics and kind of which ethical systems and reasoning should be prioritized, even if we know and try and minimize some of those biases, acknowledge where the culture and the reasoning and the people are coming from on the other side of the table. And sometimes can frankly lack empathy because it's, 8 p.m. on a Friday and we have a couple screaming toddlers at home. But I think the other thing to recognize is that we really need to also think about how we might kind of structure a path forward. So even if we kind of define what these aspects are of consultation and kind of what an ethics consultant is and really how AI models might enhance certain portions of them, we also need to know what the hell clinical ethicists think about these models, how they might actually use it, how they might actually view it. I think Spencer's example was great to really say, okay, how can we use some of those types of situations to really teach ethicists how to use it appropriately, how to engage in it, how maybe not to, which situations, not only from the reasoning standpoint or the reasoning with scare quotes around it, but also the issues of HIPAA privacy and all those other more practical things with how to engage with them appropriately. And really develop these parameters for use that make it a strength and not a hindrance. I thought that this was an interesting thing that's been around for, I think, a couple of years now, in that there are some early attempts at making ethics-specific LLMs. This is the Peter Singer bot that responds to you based on kind of his corpus of text. Notably, and I think Spencer's example hit on this a little bit too, it hedges quite a bit. So I was listening to an interview of him recently, and they were asking him questions, and then they asked this LLM a couple questions, basically the same thing. And this was just something I put into it this morning about what would it be right to kill somebody if I saved 1,000 others. And the real Peter Singer kind of came out with more, definite answers, obviously more nuanced reasoning than this thing. But I think it's more the idea that on one hand, it's malleable. You can put in Peter Singer stuff and it will spit Peter Singer stuff back out. But also because of these concerns about liability and everything else, especially with the large companies, often when you're getting into these touchy subjects, which oftentimes that's exactly where we are in clinical ethics, you're going to have it putting back these kind of vague answers about things that might not actually lead to any good recommendations or no recommendation at all. For the last couple minutes, I just wanted to touch on, well, what's going to happen if we actually have AI clinical ethicists as their own consultants. And so this is just that same definition I offered before, just with the words in AI assigned by their institution, yada, yada, yada. But this really means that we have to consider, the AI as somehow its own entity. It's being granted authority for ethics consultations by the institution and able to kind of respond to these things. And I just wanted to kind of use those competencies that the ASBH put forward to kind of think about what might we actually need to think about for this to take place, maybe not in whole, but at least in any part, kind of acting autonomously and independently. So I think even if the AI bot is not going to do this, from start to finish, you're not going to have like the Boston Dynamics dog that's at the Museum of Science kind of walking into the ICU room to talk to the family or whatever else. But just like if any of these parts could be done autonomously, like what would we need to think about and what would these competencies actually mean for that? And so we do obviously have the knowledge competencies about things needing to really pass the sniff test of, are you actually talking to and reasoning with something that is able to do so in a way that you think kind of passes that at least surface level idea of comprehension and knowledge acquisition and has familiarity with all of these things that are listed here, from the health system to national guidelines and relevant health law. And I think like in terms of those three different competencies, I'll get to the other two next. The knowledge thing, even though it's not particularly easy for an AI to do, is probably the easiest of them because it's right now where most LLMs exist. The other kind of interesting things that I just wanted to point out is that it does mention specifically awareness in this, and whether or not we think there's any sentience behind ChatGPT or any other near future LLM. I think is obviously up for quite a debate. But the last point was just what we've discussed before. It's kind of a dirty mirror of society. And if we think that the internet is actually a reflection of who we are as humans, is something I think we need to think about in terms of what these things are trained on. In terms of skill competencies and things that we would need, I think the idea that we mentioned before is we kind of have these co-pilot AIs, these assistants. We are now actually in the past couple months getting things that are more autonomous and like agent-based AIs, where instead of me saying, hey, LLM, tell me a little bit about this particular ethical theory, and it spits back something, and then we kind of have a back and forth conversation. There are things where you can have it be an agent, essentially, where you can say, hey, go do this task and like do it repeatedly and then synthesize stuff and then bring it back to me. So just repeated steps, going out into the world, doing its own internet world, going out, doing its own things, and then bringing it back to me as kind of an independent agent, or even interacting with other independent AI agents. And those things are actually coming out for commercial release just in the past couple months. And so I think those ideas of being able to do things and reason somewhat independently of that single back and forth conversation are happening. And so whether or not that is kind of happening with information gathering and being able to do that, I think like the easy example for what that might mean concretely is LLMs, or at least these agent-based LLMs, actually working as like the call centers that we all have to deal with from large companies, where that call center can send out that thing through the phone to you, you talk with it, you have an independent conversation with it, and then it brings that information back to them. That's kind of the easiest way to think about it. I know it's kind of even more frustrating than probably the conversations we're having with those things right now, but that's just kind of where it is. And I think the other large issue is kind of that idea of interpersonal skills. And the vague aspects of professionalism, really the most kind of, I think the highest bar, the most concerning, if we think that even we could have a knowledgeable and somewhat interactive AI ethicist, is really that idea of like who watches the watchers, who regulates the people who are kind of programming the AI, assuming that the AI is not programming itself. And that really, is the AI biased towards consequentialism, feminist ethics, others? If it isn't, is it going to be awfully hedging? And really, is it going to give us any meaningful recommendations, or will it just kind of defer to any strong opinion in the scenario in which it's being placed? And then, I think we have this idea of self-ownership too, in that, if we have somewhat independently acting AI ethicists, who's the person, or is the AI ethicist somehow kind of responsible for itself? Is it the person that is programming it, kind of like this longstanding debate over autonomously driving vehicles? Like, are you having Tesla who's going to get sued by somebody who gets hit by a Tesla instead of stopping at a stop sign? Or is it the person driving it? And to what extent is there shared responsibility? And to what extent, at some point, is the ownership of the AI, the institution, the AI itself, somehow, those kind of questions. And then I think the last couple things are the ideas of the uncanny valley, where we do have the closer we get to an AI being human appearing or human sounding or human acting, there is kind of a natural aversion until we get to that like very close point where they're indistinguishable, called the uncanny valley, where we're a little bit perturbed by it. And I think the easiest way to think about it is there's some of those almost like anime character, like interactive, like, models that they have at some of those tech shows where you see like the little thing, kind of dancing or whatever. It looks a little creepy, right? Like dolls to some extent, like especially those weird ones from the 1800s that you'll see on Antiques Roadshow. I never want to see one of those in my house. But, as we kind of get that close but not perfect thing, there's a lot of natural aversion we have to that. And so I think it's that whole idea is like, are we going to get to a place where it's actually going to be detracting rather than enhancing? And then the last couple parts are this idea of human dignity and respect there, because if we're coming into this and just having some autonomous AI go out and collect information for us, or go out and do different tasks that are related to the council for us, even if it is as an assistant or if it's done autonomously, to what extent is that either disrespectful as we think about it, or disrespectful as the person on the other end of the console thinks about it? And kind of, are we doing it therefore with their consent, or are we doing it separately from that? And finally, I think I just want to close as thinking about these paths forward, and remember kind of where we started with is doctors, ethicists at the bedside, then with kind of medical instruments on the physician side, with the computer for both the ethicists and the clinicians, now with AI, and really how it changes kind of the practice of medicine, the practice of ethics, and really what we need to wrestle with as we move kind of this ever more powerful ability to maintain and advance health and do it ethically, so we don't really do it at the cost of humanity. This was made on the right by the ChatGPT image search. So thank you very much, and happy to talk more.
So thank you again, both, for really at the very least, thought-provoking, if not terrifying or exciting, or fill in the blank of whatever terms you like to use. Just to start things off, I wonder, to set the stage, we talk about AI and AI in the realm of clinical ethics in a different way than we've talked about any other technological advances, I think. Do you think that there's reason for this, or is this sort of an example of AI exceptionalism, that we're making AI to be different qualitatively, quantitatively, or otherwise than perhaps it ought to be?
Good question. So I think that I think there's kind of, for any new technology, there's obviously a lot of both excitement and concern. And I feel like the kind of constellation of both the large leaps that it has made in medicine, in the past couple of years, the Nobel Prize that was won this past year for the kind of protein structure, as well as all of the kind of ways in which it has so quickly disseminated into everybody's lives, from the fact that like half the apps on our phones now have some version of AI that we've undoubtedly consented to through the long technical language that we never read, but also that when anybody has really interacted with just the free version of any of these LLMs online, it comes off, I think, a lot more as like, this is another thing that I am able to have a conversation with, whereas a lot of the other technologies I feel like are not necessarily more abstract, but have that less personal connection and have less of a trajectory that has seemed so steep. And so I think even with the internet and all this thing, there were years of people getting used to logging on. If you didn't log on to the internet, it didn't your life didn't change that much. But with this, I think the fact that we've already connected society so much, and now this is another level on top of it, and it seems like it's something that has human-like reasoning with all of the caveats that we've talked about. I think that kind of constellation makes it exceptional, but maybe not in like a way that is wrong, I would say. I think the other question, and this is something that nobody's gonna be able to answer, is like, is the trajectory like this, or are we going like this, and then there's going to be some ceiling? And I think that everybody is on one side or the other with their biases for that. But God knows if I can say what that is.
Yeah, I don't know that I have too much to add to that, other than, I mean, I think I agree. Like, yeah, wait, I had a thought and now it's escaping me. I mean, I think, yeah, I mean, it's in some ways, right? I mean, it's like you look at and you alluded to this, right? Like you think about things like the computer, the internet, right? There are these sort of other landmark technologies that clearly changed so much of our lives. It's hard to maybe know right now if sort of large language models and generative AI are going to be quite like that. But I mean, I think there is like an immediate sense with certain kinds of work that it just has to change. Like there are certain things that like I mean, the obvious example with like ChatGPT, again, because it was trained on the internet, right? It's like if you're like in marketing or something like this, it just sort of seems like, oh yeah, you have to be using this. Right? Because like the things that you produce, like it would make no sense for you to do it kind of the old way. It's like, oh, I need a new copy for this thing. Like just put it in there and start from that, right? I think there's a lot of things like that where it's just like you have to, like in a way, it would almost be like foolish to not use it. And that maybe makes it a little bit different than some things. But again, it's like if you look at the long history of technology, it's just like, yeah, well, we always freak out about these things, and then they kind of get. So yeah.
I think especially with the internet, just in general, for clinical ethics, at least, there's probably a good number of parallels with what you just said, where when the internet was coming online, and obviously I was younger than I am now for that, and I wasn't in clinical ethics, but I think being not necessarily obligated, but feeling like, oh, now I can go and much more easily search through literature to understand what people have written about this, to understand what cases have been published, rather than trying to go to Countway and look through the reams and reams of paper. I feel like as an ethicist then, I would have been like, okay, this sounds like a much easier thing to do, would probably be helpful for the situation. This seems very analogous to that, and that even if I'm not going to have the ethicist do X, Y, or Z parts of the consult or assist me in them whatsoever, I'm going to at least ask it about these particular parts. I may ask it to help out with different things to make sure that my biases aren't entering into it completely separate from my role as a clinical ethicist at Dana-Farber. I do that for a lot of my, like when I'm writing presentations or research or different things, I at least ask it questions about like, hey, am I thinking about this in a way that is introducing some bias or talking about it in a way that's not considering a different viewpoint or those kind of things. The hasty email that we write off when we're kind of annoyed at whoever sent it, even just doing it for things like that and saying like, is this, yeah, exactly. Like put it in the draft box for a little while and go from there. But I think those kind of ideas of like having it accelerate that part almost feels like a responsibility as long as we're doing it with safeguards.
Yeah, and to piggyback and maybe even push that point a little bit further, kind of using the analogy to internet and other technologies. I mean, it would be hard to imagine somebody working in clinical ethics today who's like, I haven't bought into this internet thing. I'm going to stick with my textbooks and Beecham and Childress and my old Aristotle texts, and that's good enough for me. Are we going to be coming to a point where utilizing AI at the very least as a tool, as a supplement, will be obligatory, that you'd be kind of falling behind if you're not willing to keep up with the game, as it were.
I think that's right. Like I mean, I guess we're already sort of talking about it. I mean, the story that I always like to think about is like, you know, if you were alive pre-internet, pre-Wikipedia or whatever, like there would be times when you'd like have a question and you'd be like, huh, well, I wonder what the answer to that question is. I guess I could go to an encyclopedia, I could go to the library, or I guess I'll just not know, you know, and go on with my life, right? And it's just like, that seems ridiculous to us. No, you just put it into Google, like just look it up, like get the answer and move on, right? I think that's probably right, that like where I see, I think it's, yeah, I don't know. I always feel weird, like I don't want to like predict the future, but it does seem hard to imagine the world where like this type of interface that is, I mean, even like what we have today, like a chat-based interface, which is like, yeah, just put in your question, and imagining that like, you know, probably sooner rather than later, like these systems there will be systems that are mature enough that like, that we just trust them as like, yeah, I can just ask my question and I can trust the answer, right? It's like, you know, ChatGPT isn't even that far from it. Depending on what you're asking it, like its answers are perfectly good. So I think, is that technology matures and it's like, cool, not only does it tell me the answer, but I can probe it, be like, what's your source? Let me go look at right? I think you do that enough and that is validated enough in your experience that then it does start to move into that realm of just like, well, why on earth would you not use it if it's just there, right? Because it will just save you time, right? And you can move on to the, you know, more important stuff that, you know, the LLM has no ability to do, right?
Yeah, I mean, I think that brings up a couple points. One is kind of if and to what extent there will be feedback loops between, you know, if more of the internet is created by LLMs and then it's learning off LLM created things, at which point are we able to, you know, distinguish between the two and which are just feedback loops and kind of mirrors of itself. And then the other point is more about access to these things. I know, you know, for the newest version of each, you have to, you know, pay for them. You have to have subscriptions. You have to, you know, have, for us at Dana-Farber, we have like a sandbox version where we can put in, you know, HIPAA protected materials and it stays within our ecosystem and we're able to do that. But obviously, you know, Dana-Farber has invested a lot into do that and not every place has that. Not every place has a clinical ethicist. And so there's both those push and pull of you having access to some of these kind of things if you have the resources to have that, as well as access to clinical ethicists and the resources that they bring with them and kind of how you can triangulate those things over time. I think the other point was that the idea that, you know, kind of it being obligatory, I feel like there's also a continuum within clinical ethicists as well. And so we have people who have been doing this for years. I think like the foundations of moral philosophy haven't like ground shakingly changed in the past 20, 100 years, that I think a lot of the same concepts will apply now as they will in 50 or 100 years. But at the same time, you know, those people have been around, been practicing a lot to the point where they may not have to rely on LLMs for, you know, the meat and potatoes of what they do, the clinical reasoning, the talking with families, all of those kind of things. Whether or not the LLM makes them more efficient, I think it's also a little bit of a person by person basis with how facile you are with the technologies in the first place, whether or not it's going to lead you down a better path than you would have taken or not. Because I think a lot of what we want out of this is to like enhance what we're doing, both for us as well as for patients, as well as for clinicians. But we want to do that acknowledging that there are both the costs that we know about, as well as all these potential ones that were, you know, the unknown unknowns. And so I think we just need to think about that more carefully, and to say that there's not a blanket statement that we can make about that for all ethicists either. That for the people who are being trained in it right now, this might be an awesome resource because you're able to kind of ask it if you are understanding some of the, you know, resources that you're directly putting into it correctly and saying, hey, did I get this correct when I was reading whatever very dense article that you put up there? Or am I just understanding this incorrectly? And, you know, you can also use that against, you know, whatever professor you have in class to say, hey, I asked it this, it told me I wasn't getting this right. Did I actually make an error? Because I think there is also that concern about kind of the echo chamber there. So I think just those kind of concerns and the idea that, we are all kind of continuums for different aspects of the ethics consult. Some of us do much better at the information gathering, much worse at the actual interpersonal interactions, or and our biases are all different. And so kind of how to work with those and integrate the LLMs into it at different points, I think is the idea of both having that global kind of safeguards that we need, both from like the privacy and security standpoint, as well as having some of these start to work with clinical ethicists to understand which parts of it do they actually help and for which ethicists.
So I want to zoom in a little bit on a couple, you both just alluded to some of the harms or concerns that we have with regard to AI and LLMs. And then after that, we'll see if there are any questions from folks here before we close up at the in just a little bit. But there's some kind of well-described concerns that people have about AI, not just in clinical ethics, but certainly very relevant to the clinical ethics space. So things like trust and kind of the black box conundrum of we don't really know how it gets to the point that it gets to in some fashion, and the concerns about misinformation and disinformation, and would AI be able to distill down what is actually true information that it's scraped from the internet versus something that is less than true, and then ultimately issues related to confidentiality and privacy. So I'll let you dive into any of those that you'd like to.
I mean, I guess I have some thoughts about the sort of like the truth and black box nature. Maybe I'll start there. So yeah, I mean, I guess I have a couple of thoughts on it. I mean, so one is I think that, and it actually relates, I think, something, Andrew, that you brought up as well about kind of the oligopoly. I hope, I mean, I don't know if this can happen. My hope, though, is that there will be a kind of like, for lack of a better term, like democratization coming with LLMs, that like, if, I know for a fact there are like many people who are very concerned about this and are working to like produce, smaller models, smaller large language models. Just, I know, kind of maybe I think actually some of them are called SLMs, but in any case, right? But small enough that like we can kind of have them on our own machines. So like, you don't have to have a OpenAI subscription, right? It's just like, no, you can just download this thing for free and you can chat with it. And if you imagine sort of that world where it's like, okay, you can actually get an LLM if there is ways, and I know this stuff it's complicated, but if there are ways to actually also kind of democratize the, whatever you want to call it, like the fine tuning of it, right? Such that it's like, it's not just the Dana-Farbers, but actually like every clinic could download an LLM and find ways to train it and test it to like become its own resource, right? So maybe it's not a clinical ethics resource necessarily, but sort of a tool that people can use. And then sort of see, right? Like, because that's, in my experience at least, that's where I think the trust is. It's like, look, do I really know like the internal weights of the language models that I'm using? No, right? Like exactly, how is it producing this output? I don't know that I understand that. I don't know that that is understandable, but I can certainly like through experience, like, I mean, sort of like what I talked about, just sort of think about it in terms of inputs and outputs, right? I ask these kinds of things, it gives me back these kinds of answers. And in a way, almost through like play, you can start to kind of build, and again, I hesitate to sort of personify it, but it's almost like you kind of build a relationship with it, but you just sort of come to see like, or maybe the better example is like thinking about like a musical instrument, right? You just sort of come to understand like this instrument has a character. As a musician, I learn how to make it produce particular sounds and kind of express, in the case of music, express myself through it, right? In the case of the LLM, it's maybe a little bit, I don't know if it's quite right to say you're kind of expressing yourself, but you're able to kind of get it to do the work in a way that you can trust, right? And that you start to build a sensitivity to when it isn't working right? When it's sort of giving you output and you're like, this doesn't feel right. Let me just clear out this conversation and start again, right? Because it's another advantage that it has, right? It's just like, okay, this seems to have gone off the rails. Let me start over. That I think there's a possibility like that will become kind of increasingly accessible to people. so that you can build that trust and sort of move past the point where it's just like, "Oh, I don't even know how these things work and I don't have any insight into it." So that I hope could happen.
But that does build upon, like even amplify in some ways, perhaps the equity concerns of sort of, you get what you pay for, that if Dana-Farber or HMS or whoever is able to purchase access to the gold standard and someone else is able to get the smaller version, the SLM on a shoestring budget, presumably you're not going to be getting the same outputs. And is that only going to be amplifying or even worsening inequities?
Yeah, I mean, I think that's right. I think that's kind of where we are now, right? It's like there are these like free models that you can get, and they're really not as good yet. So I think that's right. Like it's a totally valid concern. My hope is that we might see that change. I mean, again, it's like, I don't know if this is really the right analogy, but it's like, there was a time when like very few people had smartphones, right? And again, it's not like everybody can afford a smartphone now, right? But it's like, I don't know, maybe I sound like a jerk or whatever saying this or whatever. It seems like most people have access to smartphones. That's probably not true.
You're wearing the Steve Jobs outfit, so hopefully not.
I know. No, I'm like riding the subway and I feel like everyone is looking at their phone, like, and it seems like it's almost everyone, but yeah.
So yeah, I mean, I think the kind of echo chamber idea with that is also kind of brings up the idea of some of these larger models that are trained on the entire internet versus ones that we're curating, and kind of the idea of almost, I don't know, or balancing the biases of each of those things, where if we think about, Western medical ethics and the kind of the medical ethics that we've thought about in the US and kind of the systems that are the norms and the culture's norms and everything else, the LLMs that we have right now, in large part because the internet has been, fairly biased towards us in terms of the content, they're kind of reflective of us in that way, and kind of using us broadly to talk about the West. But at the same time, if we have particularly, smaller versions of LLMs that have, very curated medical ethics consultation kind of corpuses fed into them, obviously we can curate them and have your instrument that will play the particular type of ethics that you want it to reason through with you, or through the consult, or through the clinicians that don't have access to you within your health system or something like that. And I think it's just kind of like we all do every day, kind of understanding a little bit about what we're bringing into the consult room. And I'm taking this in with the fact that, this is not true, but like if my mom had dementia and I was walking in and talking to a family about end of life conversations or medical aid and dying having to do with dementia, it's obviously going to be different than a person who didn't. And just kind of having us acknowledge that is something that we're doing internally, but whether or not we can actually talk about that with a particular, or have the LLM kind of play its instrument in the way that acknowledges that it's using this particular type of ethical reasoning, and it's taking this part of, culture that it is assumed or amassed from the internet. I think it's that kind of issue and balance that we need to figure out if they can actually abide by and kind of communicate with us and kind of get a little bit at that aspect of the black box, not necessarily like looking at the technical aspects, but just understanding if we can work kind of with that program well enough to have it acknowledge or kind of say that that's specifically where it's coming from, where it might be relying on other things less. And it is kind of almost a inability of the LLM to like recognize what it's not trained on. So, and that's something that technically I don't know if it can almost be kind of made to understand that, which would be a very interesting thing.
I mean, there are ways that you can do that sort of thing. I mean, again, it doesn't really understand, probably no, I think is probably right. But yeah, that's the kind of thing though that and I actually think that's relatively straightforward, is that you can sort of build in, like in some systems, it's like the system prompt or whatever, that is basically sort of giving it some self-knowledge about like, here's what you do and what you don't do, and kind of setting up those guardrails, right? And so you could, to some extent, if you can articulate it, you could sort of just instruct the LLM. It's just like, here's what you know and what you don't know, right? And when, when it's like, challenged to go into the realm that it doesn't know, like it should just sort of say, no, I don't really think, like that's not for me.
No, I mean, I think from the standpoint of bias, I mentioned when I was speaking that, for me, one of the biggest issues in bias in clinical ethics consultation is like which ethics consults we see and are exposed to. And I think even if not in actual ethics consult, kind of whether or not we can use the models to help us identify consults more consistently throughout the hospital. If it is like, oh, a person's been on a ventilator in the ICU for 60 days or more, or kind of has these particular characteristics, or, these kind of things. I'm not saying that, I have the answer for how that should be set up, but the idea that there are probably a lot of situations that arise in the hospital that, either people are afraid to speak up about, or, there are other, issues with what's going on in the patient and kind of, oh, the person, is for some of our colleagues who are doing kind of end of life model prediction and kind of understanding when to do advanced care planning, that same idea of, okay, they've prompted the team to do some advanced care planning. It hasn't happened. Do we need to like have our ethics colleagues kind of, maybe nudge them a little bit about that in a way that just the email getting sent to them might not do. So even just those kind of ways that it's not involved necessarily in the consultation itself, but kind of helping our colleagues avail themselves of the resource of clinical ethicists.
In some ways, some of the things that many hospitals, clinical ethicists are trying to do in terms of data organization and systematizing things, but perhaps in a more systematic or more ideally systematic way than already has been done. I'm going to actually, just because we're running short on time, not open things up to questions to the large group for the moment, but we will have the reception afterwards, and I'm going to volunteer Andrew and Spencer and myself to answer questions when we're out having snacks and beverages. But I do want to throw things back to each of you if you have a short, any closing thoughts before we close up for the day.
Sure. Yeah. I mean, I think from the standpoint of being a clinical ethicist, I've started to use LLMs, not necessarily in putting patient data in there or anything, but really just having it kind of scrape the internet and bring up relevant information about a subject and help me, kind of make sure that I'm being somewhat consistent in my processes. And that's been something, as Jonathan just mentioned, that we as an organization, Dana-Farber, are trying to kind of set up our own databases and make sure that we're more consistent in both like how we're responding to consults and how we're processing them and how we're cataloging them and all those kind of things. And I think from that standpoint and helping us overcome some of those biases of who the ethicist is who's seeing you that day and what happens within that consult because of who the other person is at the end of the phone line. That part is really, I think, some of the most straightforward ways that they can really help enhance ethics consultation at this point. I think kind of a lot of these more far-fetched ways are something that I'm bringing up because we don't know if the trajectory is like this or like this. And 10 years ago, having this conversation here, everybody may have laughed. And so I think the point of like both, planning for what might come and kind of how to make sure that we're prepared for it and kind of understanding that is probably what I really want to thank Jonathan and the Center for putting this together for.
Maybe I'll just, say from my perspective, as a final remark, like, I guess I'm really excited thinking about the possibilities here. So I know we sort of talked about this one domain of sort of using LLMs for clinical ethics and, brought to it, I hope, sort of interesting thoughts that sort of provoke us to, sort of explore those possibilities. But I mean, the thing that I think is so exciting about LLMs or generative AI in general is, in a way, it's like imagining like what can be done with them that sort of we're not, like, it isn't even on the radar yet. And so I think like what I'm really excited and hopeful for, again, I mean, we want to put the guardrails, I think, around these things such that we're not, sort of ignoring all of the concerns and the drawbacks and lots of things that we sort of touched on in these domains, but is sort of, what might flow from this that we're sort of not considering, but somebody who kind of finds something really sort of groundbreaking or amazing that you can do with this that sort of unlocks whole bunch of potential. And maybe, maybe it is just sort of like somebody finds that model that is like so cheap, you can train it by just like, they find a way to just like, put the right documents in there and it's as good as, you know, the top line models, right? And everybody can have it. Like that would be exciting, I think. And, you know, we can all get the benefit from it. But that's the sort of thing that I think is part of what makes this space like really interesting. It's just sort of we're at this frontier. I think we're sort of using these tools to do things that we already know we want to do, but I think it's exciting to imagine like, well, what might be those things that we're not even on the radar now, right? That we'll be able to do that could make a big difference.
Well, thank you, Spencer. Thank you, Andrew. Thank you to all of you. Also, it goes without saying that events like this certainly do not happen by themselves. So I want to give a huge thank you to the Harvard Medical School Center for Bioethics leadership team and staff, all of you who you see listed here. And thank you all for joining us for our first clinical ethics conversation. For our next clinical ethics conversation, so Friday, February 28th, we're going to pivot significantly from the role of AI in clinical ethics to reasonable variability or unethical inequity, exploring the ethics of policy differences across hospitals. So a topic that has come up quite often around here is the fact that on very relevant and highly and frequently utilized policies in hospitals that quite literally are next door or across the street from one another, we have different policies that are ethically relevant and such that a patient who, due to no fault of their own and certainly not based on something that they could control, ended up at one hospital versus the next, would have a wildly different outcome in terms of kind of how a policy that has ethical salience would affect them and their clinical care. And is that reasonable? Are there reasons that is that ethically permissible? Are there reasons that that might be supportable, or is that unethical inequity? So the QR code up here will take you to the page where you can register. This will be a virtual Zoom only event, but I look forward to seeing you all in little Zoom boxes come February.